Hi friends, in this video I will talk about third degree heart block. It is also called complete heart block. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Complete heart block in an ECG presents with severe bradycardia due to absence of AV conduction. The ECG shows complete AV dissociation with independent atrial and ventricular rates. In this ECG, we can see complete heart block. There is AV dissociation with atrial rate approximately 100 beats per minute, independent of the ventricular rate, which is approximately 40 beats per minute. In complete heart block, there is complete absence of AV conduction with none of the supraventricular impulses conducted to the ventricles. The perfusing rhythm is maintained by junctional or ventricular escape rhythm. In this, patient may suffer ventricular standstill, which may lead to syncope if it self-terminate or sudden cardiac death if it is prolonged. Coming to the pathophysiology of the complete heart block. Complete heart block is basically it is the endpoint of either Mobitz type 1 or Mobitz type 2 AV block. It may be due to progressive fatigue of the AV nodal cells as per Mobitz type 1, for example, secondary to increased vagal tone in acute phase of inferior MI, or it may be due to sudden onset of complete conduction failure throughout the His-Purkinje system as per the Mobitz type 2 AV block. This can be secondary to septal infarction in acute anterior MI or as a result of progression of conducting system disease causing the true trifascicular block. The former, that is Mobitz type 1, is more likely to respond to atropine and has a better overall prognosis. Causes of complete heart block are same as that of Mobitz type 1 and type 2 secondary heart block. Important etiologies are inferior myocardial infarction, AV nodal blocking drugs like calcium channel blocker, beta blockers, digoxin, idiopathic degeneration of the conducting system, that is Lenegeri or Leves disease causing true trifascicular block. The clinical significance of the complete heart block is that patients with this third degree heart block are at high risk of ventricular standstill and may have sudden cardiac death. They require urgent admission for cardiac monitoring, backup temporary pacing, and usually insertion of a permanent pacemaker. The differential diagnoses are high grade AV block. This is a type of severe second degree heart block with very slow ventricular rate but still some evidence of occasional AV conduction. AV dissociation, this term indicates only the occurrence of independent atrial and the ventricular contraction and may be caused by entities other than complete heart block. For example, interference dissociation due to presence of ventricular rhythm such as AIVR or ventricular tachycardia. In this ECG, we can see complete heart block. Here, the atrial rate is approximately 85 beats per minute and ventricular rate is 38 beats per minute. And we can also see none of the atrial impulses, they appear to be conducted to the ventricle. A rhythm is maintained by a junctional escape rhythm, and we also see marked inferior ST elevations, that is in the lead 2-3 AVF, indicating the cause is inferior ST elevation MI. In this ECG, the atrial rate is approximately 60 beats per minute, ventricular rate is 27 beats per minute, and none of the atrial impulses, they appear to be conducted to the ventricle. There is slow ventricular escape rhythm. This is another example of complete heart block. Here we see atrial rate approximately 100 beats per minute, ventricular rate about 15 beats per minute, and this patient needs urgent treatment with atropine are isoprenalin and pacing. Complete heart block is seen with isorhythmic AV dissociation, that is long rhythm. We can see it in long rhythm strip. The atrial rate is 85 beats per minute, ventricular rate is 42 beats per minute. There is a junctional escape rhythm, and as the ventricular rate is approximately half the atrial rate, the rhythm at first glance appears to be second degree AV block with 2:1 conduction. However, on closer inspection, we can see the PR interval varies with some of the P waves superimposed on the QRS complexes. The ventricular rate remains regular. This confirms that atrial impulses are not being conducted to the ventricle. The apparent relationship between the P waves and the QRS complexes occurs merely by chance. So it is isorhythmic AV dissociation. Hippocrates has said, "The life is so short, the craft so long to learn." With this, I conclude my today's topic. Thank you. Keep learning.